Professor Mansour, thank you so much for the introduction of heart failure. It's incredible, as usual. And, you know, when I'm talking about NOACs today on behalf of the Pfizer Symposium, I always think that heart failure and atrial fibrillation are quite common. And we know that there was a publication just last September, a month and a half ago, that the publication was to the newest guidelines of atrial fibrillation. And as you can see through the map of the world, with the increasing of age, there is an increase in the incidence of atrial fibrillation, a very disastrous disease. And we think about it, why we're talking about atrial fibrillation, because there are so many risk factors. As we grow older, it increases. As we have more risk factors, it also increases. And we know that atrial fibrillation increases mortality, increases stroke, but if you look just behind stroke, 20 to 30% of AFib patients do have heart failure. We're not going to go into, in non-atrial fibrillation patients in heart failure, do we do anticoagulant? That can be another discussion later on. But definitely, heart failure and atrial fibrillation go hand in hand. A lot of the pathophysiologies may be actually interconnected and interrelated. So with atrial fibrillation, we have an increase in death, maybe 200%, a 3 times incidence of heart failure. Not only heart failure increases atrial fibrillation, so does atrial fibrillation increase the symptoms and problems of heart failure, but the stroke rates are immense, and this is a really important part, and that's why we're the years and years. We have different stroke prevention. I know the antiplatelets now excluded, but we have warfarin, which has always been the standard of care, and we have the novel, or the DOACs, or the NOACs, as you want to call them, the direct oral anticoagulants. Of course, in some instances, which is not so common, but you might refrain from having a pharmacological stroke prevention because you cannot give an anticoagulant, and then sometimes a left atrial appendage occlusion can be helpful. So if we just take a look at how the guidelines have shifted in atrial fibrillation stroke prevention, we're talking about now, even in those with a stroke risk of 1 or more, here anticoagulation is indicated. And here, there is a general recommendation to use a NOAC in preference of warfarin. Not because of the data, but a lot of data, not just one data. This is, of course, excluding 2 patients, those with a prostatic valve, a mechanical prostatic valve, not a biological, and those in moderate to severe mitral stenosis. And I know there are some ongoing studies to see the safety of NOACs in these subset of patients. So what comes to mind is, what is the definition of a good medication or a good drug? Efficacy, safety profile, very important, and I know now pharmacology has shifted over the past decade or two to safety before even efficacy. Its indications are it's in only a certain subset of patients or wide range, and the most important, and this is what shapes guidelines, is evidence. So what if our patient old and has renal impairment? What if our patient has atrial fibrillation and is undergoing PCI, whether it's an acute coronary syndrome or a chronic coronary syndrome? What if our patient has end-stage renal disease or very low EGFR? What if our patient is undergoing cardioversion? So atrial fibrillation is not just a single entity patient that you just say, I can give him anything or I can give her anything. We know there are a vast majority of different scenarios. And this is the question. Do we have data for all our anticoagulants or all antiplatelets in these scenarios? First of all, let's start and kick off since 2016, not just a year ago, 2016. Don't use antiplatelet therapy for stroke prevention. You can use them, of course, as an anti-ischemic or adjuvant, and we can come to that. Warfarin has always been the standard of care for stroke prevention, and it has reduced strokes by 68%. But it has been underused, especially in the elderly, for fear of bleeding. And the important thing about it too is its narrow therapeutic range. You have to have an INR between 2 to 3. And the problem is having this in the range actually is very difficult. If you want the recommended data by the guidelines, it talks about having a TTR 70% of the time. Look at the data here presented. I cannot find 70 anywhere. So it's quite a difficult medication, not because it's a bad medication, because it interacts with everything. And that is why since 2016, not just in the newest guidelines, a NOAC is always preferred to a vitamin K antagonist in a non-valvular atrial fibrillation patient. And non-valvular, again, I reiterate, is a mechanical prostatic valve or a moderate to severe mitral stenosis. So we have two targets actually present inhibitor dabigatran. We have the factor 10 inhibitor apixaban, rivaroxaban, and edoxaban. And the advantages of NOACs is their rapidity of action. They act very quickly. They don't need any bridging. The predictability of their anticoagulant effect, you don't have to routinely measure any coagulation profiles, except of course checking the kidney functions on a regular basis, and this depends on the patient. And it has very low interactions with either food, drugs, and thus less adverse events. But of course, they do have a little bit of a downside, which I don't consider a very big downside. Renal functions have to be monitored. They don't have to be monitored monthly like warfarin, but they have to be monitored. And of course, in the beginning, we didn't have, very regular or very apparent assays of how to see the patient, if the patient was on a NOAC and he got a stroke, or the patient on a NOAC and he got a bleeding, what to do with anti-factor 10 and other eccrine clotting and other lab assays were not always present. And of course, the biggest problem in very few situations, if you need a reversal agent, they're quite expensive. So what NOAC can be used in all of these? We've seen atrial fibrillation comes in different disguises. We have four, as we know: the direct thrombin inhibitor dabigatran and the factor 10 family rivaroxaban, apixaban, and edoxaban. They do differ in their renal clearance and the one that is relatively contraindicated in a problematic patient with an low GFR is dabigatran. What are their similarities? Definitely they have randomized control studies to show that they are very efficient in reduction of stroke. Not all of them are superior to warfarin, but at least their bleeding was quite low. Collectively, they are very effective, maybe significantly effective than warfarin, but definitely. Major bleeding was a rather heterogeneous between the different studies, with a predilection of lower bleeding seen with the Aristotle and apixaban, a little bit of major bleeding with the ROCKET-AF and the higher dose of the dabigatran, but overall, major bleeding is less in NOACs. But the most important and the most critical bleeding that we're always afraid of, which is the intracranial hemorrhage, is always and consistently better if you're going to give your patient a NOAC than warfarin. But they do have their differences. We need something to be safe, efficacious. Very nice. We're talking about cardiovascular mortality, and we want something to reduce mortality if we can have that. GI bleeds, another entity of bleeding that is quite dangerous, can be taken in different situations, and it has evidence, and this is a really important point. So we look at the efficacy and safety. Of course, the most consistent data for efficacy, which is superior to warfarin, has been shown in only two studies, with the dabigatran 150 milligrams and with the apixaban 5 milligrams. These are the only two medications that have shown a significant, statistically significant efficacy versus warfarin. Rivaroxaban was better, but it was not significantly different. But if you look on the right-hand side, comparing the major bleeding with the efficacy and the superior efficacy and a superior reduction in major bleeding was apixaban 5 milligrams. So apixaban actually in the Aristotle was the first one to be not only superior in stroke prevention to warfarin, but also reduction of a 31% relative risk reduction, significant, that is to say, in major bleeding, and the first time there is an all-cause mortality benefit, which was borderline significant. It was significant at 11%. And even in the elderly, of course, NOACs do better, but of course, some are a little safer than the others. Mortality, as we just said, there was a reduction overall towards NOACs, but mainly pushed by the data, 11% mortality reduction in the Aristotle, which was statistically significant. Gastrointestinal bleeds, do the guidelines address anything? Yes, actually in 2016, this was addressed in the guidelines, and this is probably the only difference that is being addressed in the guidelines from the different perspective of NOACs. If you look at the data coming from the randomized controlled studies of the different NOACs, GI bleeding actually was higher in the NOAC arms. Some significant, some less significant. Only apixaban was actually less than the warfarin. And here in the guidelines of 2016, the atrial fibrillation guidelines, if the patient is at high risk of a GI bleeding, you either use a vitamin K antagonist or something other than dabigatran with rivaroxaban or edoxaban. I don't know why you don't just say apixaban. I don't know, but definitely it is apparent in these 2016 publication. Of course, a discontinuation rate is very important, and this not only shows us a good compliance, but also an important part of the side effects. And this medication, apixaban, actually was the one responsible for the destruction of aspirin as an indication in atrial fibrillation stroke prevention from the Averroes study, because not only is it superior in lowering, aspirin is not so safe, but it is probably the safest anticoagulant we have ever given. And so many people, millions and hundreds of millions of people are already taking aspirin, we're doing fine. So if you have an anticoagulant which is more superior in prevention and also as safe as aspirin, this is a really important thing. Then we come to a thing. We have two medications that can be given once per day, which is edoxaban and rivaroxaban, and we have medications that are given twice per day, dabigatran and apixaban. And by no means am I saying that twice per day is better for compliance. It's not. But definitely, maybe the tailoring of the apixaban to twice per day has shown a steadier way of anticoagulation, a lesser probability of interaction for increased bleeding or efficacy. So if you miss a dose with apixaban, it's not as dangerous as missing a dose with rivaroxaban. If you take an extra dose of edoxaban, probability that there is an increase in peak in bleeding than apixaban. Of course, this is pharmacokinetics. This is not a head-to-head comparison. But again, maybe, and this I quote Gregory Lip and the team, that a twice daily dose of NOACs appears to follow a more balanced risk-benefit profile. Finally, evidence, and evidence is quite important. We've seen a lot of patients. We've seen a patient that is undergoing cardioversion. We have the EMANATE trial, apixaban versus vitamin K antagonist in those undergoing cardioversion. And of course, not only did it show a superiority in reduction, safety was very high and very evident. The biggest study actually, and we saw the patient that was going to undergo an intervention, was the Augustus. It was the second to last one with NOACs in PCI, and it was actually comparing two things. Is apixaban better than warfarin? Is aspirin better than placebo? So there are 4 arms actually. And if you look at bleeding, the worst bleeding you'll have with the triple therapy, and the least bleeding you'll have with apixaban alone. And this is highly significant, with the number needed to treat to reduce bleeding about 9 people. So was death and hospitalization. There was no reduction except in apixaban. Again, thus you are having an extra benefit. Not only are you decreasing the bleeding, you're decreasing also death and hospitalization, which is a safety endpoint too. And this has reiterated into the guidelines As you see, this is the acute coronary syndrome guidelines and the atrial fibrillation guidelines. They intermingle on the usage of aspirin right now. And in patients actually on any chronic coronary syndrome, aspirin can be used from a week to a month. Aspirin actually has lost a lot of ground in primary prevention, that is definite, and is losing a lot of ground now in secondary prevention when, in the context that you are taking an oral anticoagulant. As you can see, aspirin, just 1 month, and probability we can continue with the PO2Y12 from 6 to 12 months, and then it's just the oral anticoagulant. And this has been seen in patients for atrial fibrillation and PCI, even across coronary syndrome, that here you can give an oral anticoagulant in preference to vitamin K, but if it has a high risk of bleeding, so is the dabigatran 110, but it does not say apixaban, because apixaban 5 milligrams was as safe as can be. That is to say that the dabigatran and rivaroxaban had higher bleeds when using the higher doses as compared to apixaban in the Augustus. There was no increase in bleeding from the 5 to 2.5. I know this is controversial, but of course, when something is set on the guidelines, I cannot really revise what the landmark trial was, but in 2019, there was a study and published and data, and those who are with a low creatinine clearance below 15 or on dialysis, now it's not just warfarin, we can give also apixaban. This is a class 2B. It's not a very strong recommendation, and I think rivaroxaban will very shortly follow suit. So why apixaban? Efficacy and safety is there. Lower all-cause mortality and very safe in the high-risk groups without even an increase in GI bleeding. There are lots of landmark and evidence-based studies, and this is really important. So, to sum it all up, please, as much as possible, if you have a choice, and NOAC is always better than warfarin in non-valvular atrial fibrillation. Collectively, they're much better, especially in hemorrhagic stroke reduction. But if you're looking at the best, we should know that we have clinical indications with evidence for apixaban in recurrent stroke, the superiority, and it was superior. The high risk of GI bleeding, guidelines since 2016, PCI seen by Augustus. If I have a GIT symptoms or dyspepsia, it doesn't increase. The high risk bleeders, cardioversion in the MN8, and of course, if we can have renal impairment, this is another thing seen by the 2019 American guidelines. So my take-home message is, anticoagulation, integral part of atrial fibrillation. Warfarin has been the gold standard, and it's still a very good medication, but with the advent of the NOACs, I think it's all over, except of course in certain indications of valvular atrial fibrillation. Not all NOACs are the same. We have differences in the renal, differences in their outcome studies. And here, you might have to consider a drug that has been indicated in all the situations we have discussed. And thank you.
Thank you, Dr. Ahmed. Dr. Mansour.
Please, Dr. Mansour.
Dr. Ahmed, thank you for excellent lecture, as usual. I have small comments. As we know, all search for the ideal anticoagulation, but unfortunately, until now, there is not present actually. But the physician, when we start the NOACs, as we know, the last few years, is widespread using its atrial fibrillation as an indication, must we know how to start. It's very important. And when we start, how to interpret the coagulation cascade or profile in patient under usage of NOACs as regard INR, TBT, because the different types of NOACs differ from each other as regards the effect on coagulation. My questions, Professor Ahmed, as regard the heart failure with atrial fibrillation, what about the efficacy of NOACs on left ventricular, having left ventricular apical neural thrombus, efficacy as regards patient, and also the safety if some patient with heart failure and atrial fibrillation associated with right sided failure, and the same time the liver congestion. What about the safety in this case? Thank you.
So much for the kind words. Thank you all. A very good question about the LV thrombus, and there are so many conflicting data. The standard is still warfarin, but there are data to suggest that rivaroxaban is not good. There are data on rivaroxaban which is excellent. There are data on other anticoagulants, some small studies, but there is no head-to-head comparison really. I think the safest is using warfarin if you have it, but I think if we have a bigger amount of patients and study them on the left ventricular apical thrombus, this might be. Second of all, we should understand also that left ventricular apical thrombus really usually occurs a lot of the times because of an ischemic event, an aneurysm that occurred in the apex of the left ventricle. So there are a lot of pathophysiology. So which one of which? We have patients on that, on NOACs, and we have patients on warfarin. I'm sorry, I didn't get the second question, Professor.
As a drug, the safety of NOACs in presence of left ventricular damage or left ventricular failure. As you know, there is a score, child score, for as bleeding versus thrombosis. What about the age of NOACs in presence of liver cell impairment?
Okay, again, if a liver cell impairment or liver failure has a lot of degrees. If the patient is already anticoagulated because of the decrease in the coagulation profile of the patient and has an INR naturally above 2, he doesn't require anything, or she doesn't require anything actually. No warfarin, nothing. There is a concern mainly because of these of liver cell. There is no big data on patients having various degrees of hepatic impairment with the NOACs, but I think in mild and moderate cases it is safe, definitely.
Yeah. Thank you, Dr.
Dr. Ahmed, I would love to add something about dabigatran. It needs first, I guess, to be absorbed through the gut, and then it recirculates once more. And that's one of the most important drawbacks for patients who have GI troubles. It's not very recommended for those patients. Secondly, what would you recommend in the NOACs for a patient who is 85 years, for instance, with creatine 1.5 and a low body weight like 60? Do you think, I guess these are the precautions for apixaban. Do you agree with me?
A great case presentation. I love that. Again, I'll tell you something. Apixaban 2.5 is not a potent medication. Let's really take it into consideration. And there is an overusage of the 2.5 milligrams of apixaban. It should not be used that much. It should have a rule of 2 out of 3. If the patient has any 2 of the 3 following, he should reduce or she should reduce their dose to 2.5. Age above 80, creatinine 1.6 or above, and a body weight below 60. Apixaban safety has been shown that even the 2.5 can be given starting from very, very, very low GFRs. Not like rivaroxaban. Rivaroxaban can be used at the 15 after we go lower than 50 EGFR, glomerular filtration rate. So don't use the 2.5 unless you have 2 of the 3 that we just said about.
Okay, last point worth noticing, some patients who have chronic indication for anticoagulation like atrial fibrillation and are going for PCI, those patients are receiving already VK antagonists, and I guess that the latest recommendations would say if you have an INR which is less than 2.5, you still have to give on table a reduced dose of enoxaparin and ultra-fractionated heparin, as well if you're still, the patient has received a last dose of new oral anticoagulants, still this patient must receive the reduced doses of enoxaparin as well as UFH. Do you agree with this?
Oh, this is excellent, very good point and very important point, because sometimes we are not really following the guidelines. Heparin should be given if we have the dose according to the medication, if it's vitamin K antagonist or non-vitamin K. And I invite all to revise the new ACS guidelines. They have a great algorithm on what to give, when to give them, because we don't want also stent thrombosis and coronary artery thrombosis.
Okay, the last thing is, of course, which has been proved that for renal functions, the neural anticoagulants have less impact on renal arteries calcification, in contrast to the VKAs like warfarin that would cause later deterioration in renal function. Do you agree on that?
This is a study, but it has not been reiterated that patients at high risk for renal disease should not be given, warfarin. So I know there are a lot of studies, and even studies that show that some NOACs are even better than others when talking about the renal deterioration. But this has not really been, upgraded in the guidelines and the way of management between us physicians. So
Well, thank you very much, Professor Ahmed. If no other questions, we will conclude the session. Well, thank you very much.